Good evening, everyone, and welcome to tonight's presentation entitled COVID in the Church. My name is Dr. Randa Anderson, and I am the new president of the Orthodox Christian Association of Medicine, Psychology, and Religion, OCAMPR. OCAMPR is a professional organization that serves to provide interdisciplinary collaboration and fellowship amongst Orthodox Christians in the healing professions. Every November, we host a conference that focuses on a theme, and we gather together to present and hear speeches, workshops, and papers on that theme. This year's conference was held in Phoenix, Arizona at Holy Trinity Greek Orthodox Cathedral and focused on the theme, Care in a COVID Era, Unity and Truth in Uncertain Times. Tonight's panel is a workshop that was scheduled to be presented at the November conference, but due to technical difficulties on the ground in Phoenix, we had to move it online, and so we are offering it tonight. So for those of you in the audience tonight who were registered for the conference and know the struggles we had trying to offer this panel simultaneously in person and online, we thank you again for your patience. For those of you who were not registered for the conference but are attending tonight, you're getting a taste of what OCAMPR does so well. And that is offer interdisciplinary dialogue on topics that are relevant to us as care providers and to the people we serve. We will be taking questions from the audience at the end of the presentation, so please put your questions in the chat throughout the presentation as you have them, and we will offer them on your behalf to the panel. This presentation is being recorded and will be on our website within the next few days. And now I'd like to introduce Dr. Gail Waloszak, who is our moderator for tonight's panel. Dr. Waloszak is a professor of radiation oncology at Northwestern University and associate dean of the graduate school. She also has a DMin in Eastern Christian Studies and is adjunct professor of religion and science at Lutheran School of Theology. She is a past president of OCAMPR. Dr. Waloszak, thank you again for putting this panel together and moderating tonight. Take it away.
Thanks so much, Randa. I'm really happy to be here, and I'm happy to finally get to host the conference. We have 4 speakers tonight. The first one, we're covering all areas. We're covering the science of COVID. We're covering the medicine of COVID, the theology of COVID and its influence on the church, and then we're talking about the ethics. So we have 4 speakers, and what the intention tonight is to have all 4, each speaker will present for maybe 10 to 15 minutes, and we'll then allow them to have a little bit of dialogue among themselves, and then we'll handle any questions that come in the chat. But please feel free to enter your questions in the chat as they come to your mind, and we'll be prepared to handle it. Now, these all are esteemed speakers, and I could probably spend the entire time just introducing them. So we've all agreed that we are going to just have a very short introduction, and more information is available about them on the OCAMPR website. So our first speaker tonight is Dr. Hermina Nedulescu. She is a neuroscientist at Scripps Research in San Diego. She focuses on neurobiological aspects of abnormal behavior and neuronal circuit functions relevant to human psychopathology. She's also an instructor for Stepping Higher, a faith-based nonprofit organization dedicated to faith-based leaders, including clergy, pastors, and behavioral health providers. With that, let me welcome Hermina and ask her to start off and to share her slides.
Hey, thank you for that introduction, Gail. Can everyone see my slides okay?
Yes.
Okay, perfect. Good. So, yes, good evening. Today, my talk will be focused on pandemic safety measures and some topics of behavioral health. Okay, so, but before we jump in, let's review the routes of transmission for SARS-CoV-2. This is the coronavirus causing the current pandemic. There is different variants of it, but it's still SARS-CoV-2. The primary route of transmission is by inhalation, and there's a secondary route, and that is through direct contact with contaminated surfaces. Okay, so the reason inhalation is the primary route is because some virologists predict that the size of the inoculum, meaning the number of viral particles that are necessary to instantiate an infection, is in the order of magnitude somewhere in the several hundred viral particles. And so if you are in an indoor environment that's not well ventilated, next to an individual who's highly infectious and perhaps not wearing a mask, then over time, over 5, 10, 15 minutes, we can inhale enough viral particles to instantiate this infection. Whereas through direct contact, if we can imagine that we kiss an icon and we leave a smudge of saliva behind, it's not known that in that context, enough viral particles would remain to instantiate an infection. I would still be careful, and I would avoid that as well. So the 3 routes of entry of this virus into the body, and this is what the virus looks like, an image of it, is through the mouth, nose, and eyes. These are regions in our body that are lined, have lining with a receptor called an ACE2 receptor. The ACE2 receptor is what the spike protein, you see the spike proteins here on the virus, binds to the ACE2 receptor like a locking key, and is the first step that initiates and allows this virus to enter the host cell. There are 2 mechanisms by which the virus ejects its genomic material into the host cell. And these are important because you can see immediately why hydroxychloroquine was never going to work. And that is because there are 2 mechanisms. One is where the virus, here, let's look on the right, where the virus attaches to the ACE receptor and then immediately ejects the viral genetic material into the cell. And another pathway is where the virus attaches to the receptor, buds in part of the membrane of the host cell, and creates this endosome. And hydroxychloroquine works at that endosome. It inhibits that endosome. However, hydroxychloroquine would not work in this other case, in this redundant pathway that the virus can enter. So that's important in my opinion to know. All right, so we have some mitigation measures, one being vaccines. And I want to talk a little bit about that because on the Orthodox Theological Society in America website, we have created, my colleagues and I, including Gail, Gail Wolashak and Dr. Chris Matthews, a vaccine document with useful information about various vaccine technologies, as you can see in this panel here, as well as how the current mRNA vaccines work. And I will share these links with you at the end of my presentation. So now I want to go back to the mitigation measures. So one is to vaccinate. The other one is to wear masks indoors, because this really helps. Because this virus is airborne and it is transmitted via inhalation. So by wearing a mask, that can protect the people around us. Of course, the indoor environment should also be ventilated, and you can monitor how well the indoor environment is with a CO2 meter, and I will show you how that is done. Other measures in the church settings include to disinfect the communion spoon or change to a new spoon. Also consider creative ways, especially at the moment, because we are in a pandemic time, to venerate icons that limit us leaving saliva behind for the next person. Sunday schools and fellowship hours, we really should try to have them in ventilated or outdoor areas, weather permitting. So Here what I'm showing you is how one can measure the CO2 levels. This is upon my visit when I went to church on September 19th on a Sunday liturgy. This is a church in San Diego that has a 100% mask compliance. They have consulted with an expert and are pumping air from the outdoors inside to exchange the air. They have filters, infrared purifiers, Sunday schools outdoors, fellowship is outdoors, and vaccine information sessions. So when I went in at around 9:30, which was in doing orthos, on the x-axis here you have time, on the y-axis is CO2 concentration in parts per million. So CO2 is what we exhale out of our mouth. And if the indoor environment is not well ventilated, this CO2 concentration, if there are a lot of people indoors, can really jump in. Like, for example, in an airplane, it can be as high as 3,000 parts per million. So in this church, the purple line is my recording. Just so you know, outdoors, the CO2 concentration is around 400 parts per million. And you can see that around 10 o'clock, when liturgy starts and people start coming in and the church begins to get filled, you can see the CO2 concentration increasing. And around when the liturgy is finished, people leave, it begins to decrease. So the nice thing is that in this church, because they are pumping air from the outdoors, they are exchanging the air, the CO2 concentration doesn't go above 800 parts per million. And that's the key, because once it's above 800 to 1,000 parts per million, that's when I would consider, well, not just I, but other aerosol experts consider that environment is not well ventilated, and the advice is to remove yourself from that environment, because if there is an infected person, the risk of getting infected is much higher. All right, so now I'd like to switch gears to another dilemma. In August of this year, I was asked to write an article about how the Orthodox Church handled COVID measures. And so this is more on the behavioral side that I mentioned at the beginning of my presentation I would talk about. So in 1771, there was a plague that hit Moscow. And what happened is that the people were gathering because there was an icon of the Virgin Mary known as the Theotokos of Bogolyubovo, which was proclaimed to be capable of ending the epidemic. So the people were gathering around this icon during this epidemic. And so the Archbishop, his name was Ambrosius, realized that the crowds that were gathering to kiss the icon and just venerate were aiding in the spread of the disease. So what he did was he hid the icon in a shrine nearby. And as a consequence of this pastoral act, the people became very anxious and sought him out and killed him the next day. This is an extreme example, of course, but what I want to point out is that it is this idea of anxiety and mistrust that led the people to disobedience and just strike out. Gail, how am I doing on my time? Okay, I will just keep going. So, because what I want to
about a minute.
Okay, what I want to insert here is that the problem of anxiety and lack of trust is really at the heart of the human condition. We have well-described examples in an example in the Bible. Perhaps we can recall Exodus chapter 16, where the Hebrew slaves that were delivered from the Egyptian taskmasters, they found themselves starving in the wilderness. And well, they complained to Moses and Aaron, stating that they would rather have died in Egypt on a full stomach than starving in the wilderness. God responded to this complaint by delivering them manna every day, every morning to sustain them. Moses requested them that they only take what they need and to trust that God will provide the next day. food for them. However, the people did not trust, and instead what they were doing was where they were hoarding the food. And Moses insisted, please take only what you need, because the food that they were hoarding was actually spoiling right away. And so here is an example again of mistrust leading to disobedience and not listening to Moses. My point here is just to show that it really is at a condition. Okay, so with this example in this article, I also highlight the difficulty that the hierarchs are in during this pandemic. And another topic I talk about is misinformation, in particular regarding vaccines. With that, I had the article. I asked Dr. Helen Theodoropoulos to read the article, and she gave me a challenge. She said, now that you have pointed all of these problems out, what are you going to do about it to promote unity instead of further polarization? So being a brain and behavioral neuroscientist, I started thinking about what is it that even when people are presented with facts, they still believe in misinformation. So I did some research, and there are a couple of things I want to mention here. One is motivated reasoning. It personally benefits the person to believe the misinformation. Maybe they just want to help, actually, or maybe they just want to make sense of events, and perhaps they don't have enough training to distinguish between what is truly true and what is false. There's also social support, holding certain beliefs that can be crucial for belonging in a group, a family that has certain beliefs. Also with social media, we have instant gratification with the likes when we share something that is holding to these beliefs. There's also something called anchoring bias, and that is putting a strong belief in the first thing you hear about a topic. And an example of this is in the beginning of the pandemic, there were some thoughts about that children are not affected by COVID, which is actually not true. Children are, of course, at lower risk of dying from COVID, but they are not at no risk, and we don't even know the long-term effects. But this first, instance of people saying this still leads all the way until now, until parents don't want to vaccinate their children because they believe they're not at risk. So I turned to some psychology papers, and so how do we fix this? In this study, what they found is that simply asking the participants, how accurate do you believe is your information that you are about to share on social media, actually prevents them from sharing false information. So that's one thing we can do. Is ask ourselves before we share. Instead of sharing very quickly, ask ourselves, how accurate is this information? And this is supplemented by a new document from the Office of the U.S. Surgeon General, where it's a wonderful toolkit about how to identify false information. For example, here you have breaking news. The doctors are hiding important information about the virus. Listen to what this one nurse has to say. So this is a red flag, because there is not one nurse or one single doctor that, that can make sense of everything. We really have to bring all the experts together. They also have a checklist, which you can check out. But some of the things they recommend is check whether the information is also available on websites, reliable sources such as the CDC or the local public health, and ask and check with doctors or nurses, scientists. And of course, if you're not sure, just don't share is the recommendation. There's a lot better information here that I'll let you check out. That's it. I'm finished. Thank you.
Okay, very good. Thank you so much for that. And one thing I wanted to note is that paper that's on the OTSA website, Kathy Polos was actually one of the authors on it as well, and she was an OCamper speaker, keynote speaker this year, so that's really great. Our second speaker for this session is Dr. Cheryl Johnson. She works as a hospitalist at Cape Coral Hospital in Cape Coral, Florida. She's a member of Annunciation Greek Orthodox Church in Fort Myers, Florida. And where I know Cheryl from is that she's actually served as a medical missionary in the OCMC, gone to many different places, done a lot of mission work, and she's currently on the OCMC board with me as a chair of the medical missions for OCMC. Cheryl, it's such a joy to have you here, and I know that I am to project your slides, so let me just get those up right this minute.
Thank you very much, Gail. And thank you, Hermina, for giving us a good basis of the biology of the COVID virus. I'm going to talk a little bit about the more practical parts.
Is this in presenter mode or is it in?
Sure.
Is it in presenter mode or not?
It's in presenter mode.
Okay, let me flip it.
Perfect.
Thank you.
All right. Next slide, please. So Hermina already alluded to this. So let's talk a little bit about transmission of the COVID virus. The incubation of the COVID virus is up to 14 days following exposure, although most cases do occur within 5 days. So I don't know if you've experienced this, but at our hospital, if someone is exposed, they are required to stay out the whole 14 days just to make sure. We know that COVID does have asymptomatic infections where people did not know they were infected, but it is good to know that those people also can pass the infection. As Hermina said, direct person-to-person respiratory transmission is the primary means of transmission. Transmission can occur from contact with contaminated surfaces, although this is not thought to be a major route of transmission. So all that aggressive cleaning that we did of our groceries and our surfaces were probably a little over the top, but that probably prevented maybe 1 or 2 infections. You are most contagious, and this is interesting, from 2 days before your symptoms to 1 day after your symptoms. So a lot of people pass the virus before they even know they're sick. And it declines within 7 days. In the hospital, we consider if someone is 10 days out from their first symptom that they are no longer infectious. And again, that's giving a little buffer because really within 7 days is when it really declines. As Hermina said, wearing masks and social distancing have proven effective both in protecting the wearer from infection. So if I'm in contact with someone who has the virus, I'm protected by my mask. And also, if I have the virus and maybe don't even know it, I am protecting the public from infection from me by wearing my mask. Next. So quarantine versus isolation. We hear a lot about these two things. Quarantine is for people with known or suspected exposure, not for infection, and that is a 14 days. And that's a pretty, like I say, a rather generous amount, but that is what has been established. Isolation is for individuals with known or suspected infection. So it lasts 10 days from the first symptom or from the positive test, because some people do test positive even though they're asymptomatic because they have an asymptomatic infection. Now, if you're in quarantine and you develop symptoms, then your 10-day quarantine restarts from the date of your first symptom. Next slide. So what does the infection look like? Well, we know that the COVID-19 infection is all over the board. The bolded symptoms are the most common: cough, headache, sore throat, myalgia. But a lot of people have fever, shortness of breath, diarrhea, nausea, vomiting, and then the loss of taste or smell that we all hear about. The serious complications, the things that will land you in the hospital and sometimes eventually lead to death, include respiratory failure, thromboembolic complications, that's blood clots, inflammatory complications, ARDS, which is lungs, cardiac complications, and neurologic complications. Next slide. So who's at risk? Well, we're all at risk, but the people that are at risk for the most serious disease are those with cardiovascular disease, those with diabetes, those who already have compromised lungs. There we go. People that have cancer, immunocompromised, someone who has chronic kidney disease, people who have a history of a transplant, specifically a bone marrow or a solid organ such as a liver or a kidney, obesity, and smoking. And you can see that several of these risks are related to already compromised lungs. All right, next slide. Prevention. Well, we know there's no known way to completely prevent infection. COVID-19 is a virus, and viruses are known to mutate, and this one's really getting good at mutating, and I think some other people are going to talk about that later. And the influenza is a good example. Why do we have to get a flu shot every year? Well, because the flu that we got vaccinated against last year may not be the flu that's coming around this year. We have had some success with permanent eradication of some viruses, such as hepatitis B and smallpox. But current scientific thinking is that the COVID-19 virus will behave more like influenza and probably require yearly boosters. Next slide. Vaccine. Well, we know that the vaccine does not prevent reinfection by COVID variants, most recently the Delta variant, but it shows significant protection from severe disease. I don't have any official statistics, but in the hospital, and in my role as screening patients for the monoclonal antibody, I found that the vast majority of the patients in the hospital with the Delta virus were unvaccinated. The exception to this were the patients who are immunocompromised and just weren't able to mount an adequate response to the vaccine in the first place. Next slide. So how do we treat COVID virus? Well, the only outpatient treatment we have is an antibody made by the company Regeneron. It's casirivimab and imdevimab. And when they first came out with the Regeneron antibody, they had very strict criteria. But in the last few months, they have opened up the criteria. So most people that get COVID are eligible for the monoclonal antibody. So this is just age, BMI, pregnancy, chronic kidney disease, diabetes. Anyway, the list is quite inclusive. Next slide. But the monoclonal antibody is only effective if it's given within 10 days of the first symptom. So people that are diagnosed with COVID need to contact their doctor right away to see if they are a candidate for the monoclonal antibody. It can be given IV or sub-Q, and it lasts about 30 days. So essentially, you're getting the antibody directly. You're not having to, it's not like a vaccine where we're stimulating our body to make the antibody. We're giving you the antibody, but it's a short acting. It lasts about 90 days. So everybody I talk to, I say, wait your 90 days, but then get your vaccine if you haven't gotten that, or get the booster if you're eligible for that. Next slide. The only additional outpatient treatment is just symptomatic. Cough syrup if you have a cough, Tylenol or ibuprofen if you have aches and pains and fever. Some physicians will give 10 days of Decadron or prednisone, although preliminary studies have not really shown any benefit for patients that are on room air. Next slide. What about ivermectin? Well, we've heard a lot about alternative therapies, and Hermina talked about one of them, the hydroxychloroquine. But we know that COVID-19 has evolved rapidly as the scientific community has put in incredible time and resources into this deadly pandemic. Many treatments were considered early in the course of the pandemic, and many of them have been shown to be ineffective and sometimes harmful. And I thought that was interesting when Hermina talked about misinformation. What you hear first is what sticks with you. And some of this has stuck with people, even though it has been since shown that these treatments are ineffective. So things that they've tried were hydroxychloroquine, interferon beta 1b, IVIG, baricitinib, but that's still undergoing clinical trials, so we haven't really completely crossed that off. Lopinavir and ritonavir, which are HIV meds, oseltamivir, which is Tamiflu, and ribavirin, which is used for hepatitis C. So they've tried things that worked for other viruses, but they have not been shown to be effective for COVID-19. Next slide. What about ivermectin, though? We've heard so much about it. Well, ivermectin has been shown to have in vitro activity against the SARS-CoV-19, but no data has been found that translate to in vitro inhibitory concentrations of the drug to pharmacokinetically equivalent human dosing regimens. There have been studies that have shown it to be effective, but these studies are seriously flawed, and when strict scientific scrutiny looked at these studies, they just did not hold up. Clinical studies are continuing, but right now there is no evidence that ivermectin is an effective treatment. The other issue is that ivermectin can cause increased liver enzymes, which is also one of the things that COVID can do. So sometimes it can cause more harm. And especially when people are buying it at their local feed store and not managing the dose, people have had serious side effects from using unregulated ivermectin. However, I must say ivermectin does remain the drug of choice for multiple parasites. So it's not that it's a bad drug, it's a very useful drug. It's just not a COVID-19 drug. Next slide. So let's talk about serious COVID illness, severe COVID illness. What lands you in the hospital? Well, the most common cause for hospitalization for COVID-19 infection is hypoxia. And that originally was defined as an oxygen saturation less than 94% on room air. Although most of the time we've used, because the hospitals were so overwhelmed, we've used 90% or below. When a patient has to be admitted to the hospital for hypoxia due to COVID-19, they are immediately started on 3 treatments in addition to oxygen. One is remdesivir, which is a nucleotide analog. Studies on that are weak, but they do not show any harm and they may show some benefit. So everybody gets it. Decadron, which is a steroid, studies on that are pretty strong, and the Decadron does seem to help with the inflammatory response that the COVID-19 stimulates. And then Lovenox, which is an anticoagulant, because early in the disease, we started seeing that a lot of COVID-19 patients were developing blood clots. And so we discovered that COVID-19 does increase the clotting cascade in your body. So everyone goes on Lovenox to prevent blood clots. Next slide. So let's talk a little bit about remdesivir. It was originally started for use with Ebola. It's still in clinical trials. It's still an experimental drug that's approved by the FDA under Emergency Use Authorization Act. It's an IV medicine and it's generally given for 5 days. But what we are finding is that the patient can be weaned off the oxygen and they're feeling better, then we just discharge them home before completing the treatment. Studies of remdesivir in hospitalized patients with non-severe COVID have only showed modest improvement with treatment. Studies of remdesivir in hospitalized patients with severe COVID, patients in the ICU, have not demonstrated a clear major benefit, although right now we are using it just because our arsenal of things to treat severe COVID is so limited. Next slide. So patients with high oxygen requirement are intubated patients. So we do have a few, again, experimental drugs that we are using in the ICU. Tocilizumab, which is being used on a case-by-case basis, and it must be used in conjunction with dexamethasone. And then baricitinib and tofacitinib are also being used in severe situations. But the studies are ongoing, the evidence is not absolute, and they are usually reserved for use in the ICU in very severe patients. Next slide. So anticoagulation, we've talked a little bit about that. We've said that COVID-19 has been shown to increase the risk of blood clots, particularly for people with severe illness. We have a lab test called the D-dimer, and that's being used to guide anticoagulation treatment. So in the hospital, all patients are started on a higher dose of Lovenox than usually used for just prophylaxis. The D-dimer is then monitored throughout the hospital stay. If the D-dimer increases, then we do another study for a blood clot in the lung or a pulmonary embolism. It doesn't always mean they have one, but we have found several pulmonary embolisms because that D-dimer started going up. So if you have a DVT, which is a deep vein thrombosis, usually in the leg, or a pulmonary embolism in the lung, or continued high D-dimer, these are indications for the use of an anticoagulant on discharge. And so these people will go home with some of these newer anticoagulants such as Xarelto or Eliquis, usually for only about 3 months, sometimes as many as 6 months. Prophylactic anticoagulation is not usually recommended for outpatients with COVID. We did at first put everybody that left the hospital on an anticoagulant, and then we had increased risk, we had increased bleeds. So now it has to have specific requirements for a person to go home on an anticoagulant. Next slide. Talk a little bit about long COVID or post-COVID. I know people are talking a lot about that. We're still learning. It's a term to denote persistence of symptoms in those that have recovered. And that is currently defined as symptoms lasting more than 12 weeks after your initial onset of symptoms. Can be continuous or it can be relapsing and remitting. The most common symptoms that people complain about are fatigue, chest tightness, palpitations, myalgia, aches and pains, shortness of breath, and difficulty with focusing. There is a subset that has ongoing fever and GI symptoms. The risk factors seem to be female, advanced age, or more than 5 symptoms in the acute phase of the infection. And again, the most common symptoms in the acute phase that put people at risk for long COVID is fatigue, headache, shortness of breath, hoarse voice, and myalgia. But I just want to emphasize this is still we still do not understand this, and there's no way of really knowing at this time who is going to develop post-COVID syndrome. Next slide. So again, to summarize, the treatment for COVID is symptomatic treatment, follow up with healthcare providers, lab monitoring. This is the treatment for post-COVID. Symptomatic treatment, follow up with healthcare providers, lab monitoring, and a high awareness for new or worsening symptoms. Next slide, please. So final recommendations: wear your mask, continue to social distance, get your vaccine and your booster as recommended. Respect the virus. There is still a lot we don't know. Do not become complacent just because the numbers are decreasing. We will never get back to normal. Life will get better. We will learn more. And COVID-19 may become just another virus requiring a yearly vaccine. However, we have learned that the potential for a worldwide pandemic exists, and there are more diseases out there. And last of all, support ongoing research and development. That's how we're going to get on top of this and get on top of whatever comes. Thanks very much.
Thanks so much, Cheryl. This was really great. I hope I stopped sharing my screen. We'd like to go on now to our next speaker. And I'm sorry, I have to get out of this in order to do that properly. There we go. Thank you. I'm sorry. So our next speaker is Father Anthony Rober. Father is a professor of church history at St. Vladimir's Orthodox Theological Seminary and second priest at the parish of All Saints of North America in the Antiochian Orthodox Christian Archdiocese of North America. His most recent and current work includes Mixed Marriages in Orthodox History, the edited volume Human versus Religious Rights, and the forthcoming Orthodox Christians and the Rights Revolution in America. Father Anthony came to my attention because he was constantly emailing about concerns during COVID within his own parish, and his interests here have been really very important. Father, please.
Thank you, Gail. I'm going to read my remarks because I want to be careful about what I say, so I apologize for not looking at you directly. I deliver these observations as a professional historian, as well as a member of the Orthodox clergy. The first point I want to make is that bad as the pandemic continues to be, it has laid bare an even more worrisome disease, what commentator Jonathan Rout and others have labeled our epistemic crisis. We're living in a time when the hard-fought methods of establishing the most probable truth of human knowledge, whether in the hard or social sciences or the humanities, are under assault. Because the struggle to come to some sort of consensus about what is probably true took shape in the 17th century. As an early modern historian, I've spent a lot of time trying to teach students about the origins of how we arrive at what we can reasonably consider a consensus of informed opinion about what constitutes truth and truthfulness. I start with this point because, alas, when we ask how the Orthodox have handled the pandemic crisis, we've discovered that as a church, we suffer from deep-seated suspicions about political, academic, and ecclesiastical sources of knowledge and counsel and expertise. We should not have been surprised, given the difficulty the Eastern Orthodox have of agreeing among themselves on a lot of global issues, the issue of primacy, for example, and therefore any attempt to assess what the Orthodox Church has said and done with regard to the pandemic has to recognize the fragility of the Eastern Orthodox capacity to articulate a common set of priorities and actions when faced with global crisis. Now, to be fair, this fragility is not confined to the Orthodox. Even a global communion organized around a supreme pontiff, the Roman Catholic Church has encountered deep divisions within its own members over the question of how Christians should understand and behave in the face of a profound threat to human life. Now, the question of how the Orthodox have responded to the pandemic unfolded, I think, in two steps. First, of course, we should note the so-called COVID and communion debates, and second, then, with regard to the issue of vaccination. We should take note of the eventual positive perspective that various Episcopal groups and patriarchates came to adopt, namely, that obedience and compliance with what health officials and authorities and scientists believe to be necessary responses to the pandemic must be undertaken out of love and compassion for the very young, the weak, the elderly, the chronically infirm, for health workers and first responders. In other words, for those most vulnerable. It would have been helpful to have heard this correct perspective articulated earlier and more forcefully than was the case, but its articulation needs to be recognized and applauded nonetheless. In the early months of the pandemic, given the changing assessments of the disease among expert virologists and government officials, it is not surprising that Orthodox bishops were uncertain as to what their advice and instructions to their churches should consist of. As reports spread of how contagious the virus was and how severe its impact could be, many bishops fell under intense pressure to close all of the churches. That pressure did not come primarily from government officials, but from Orthodox Christians themselves. And at the very same time, the bishops faced the opposite demand, that the churches and communion practices be maintained unchanged at all costs, because the argument was any concession to closing the churches or altering conventional communion practice amounted to a lack of faith in God's care for his people. This division of opinion and the resulting conflict in demands revealed an alarming lack of understanding on the part of the Eastern Orthodox about the realities of contemporary scientific knowledge regarding viruses and epidemics, as well as considerable confusion about how a believing Christian should integrate that knowledge with current practices of communal and private piety. Sadly, as of the autumn of 2021, to the extent that we have reliable data, it appears that the infections and death rates among the Eastern Orthodox remain highest in Eastern, Southeastern Europe, Ukraine, and Russia. The death of the Serbian patriarch, one of that church's eminent metropolitans, along with priests, deacons, monastics, and faithful, appear to have been the result both of governmental failure to take steps to contain the virus, but also because of the opposition of some Orthodox church leaders about the closure of churches, the necessity of masking, social distancing, and eventually vaccination. Echoes of those tendencies can be found in some Orthodox groups around the rest of the world, but to a somewhat lesser degree. Now, apart from the debates surrounding lockdowns, the most intense and in some respects most disheartening response to the pandemic emerged over these two issues already mentioned, reception of the Eucharist and the question of receiving the vaccines. Some of us have argued from the outset of the debates over COVID and communion that historical evidence has confirmed that during outbreaks of epidemics, the Orthodox Church has historically adjusted its communion practices. It has closed churches. It has continually accepted the reality that illness and mortality are not avoidable by virtue of one's presence in a church building, in the altar, or in the reception of the mysteries. For the Church's bishops to say that it is not possible to become ill by receiving communion is not an adequate statement, and in fact can be quite misleading. I doubt that any Orthodox questions the potential of the Eucharist consumed after the metabole of the anaphora to heal both soul and body. But if the elements are simultaneously divine but nevertheless physical and subject to temporal conditions, and they are, wine will turn to vinegar, that lamb will mold if it's not cared for properly, there is still gluten intolerance for people who cannot take the lamb, and the list could go on and on. If we accept that reality, then one cannot avoid the conclusion that the presence of a virus in the humans who are handling and especially breathing on the chalice, the spoons, the communion cloths, and each other ought to have been sufficient evidence for everyone to agree that temporarily suspension of services and distribution of the Eucharist was both historically consistent with the obligation to prevent infection of the most vulnerable, but also most importantly as the highest form of agapic love to which the Church is called. Faced with opposition to this reality, many bishops unfortunately relented to take a position defending the use of the common spoon in distribution as if this practice were somehow historically linked to a dogmatic teaching about the nature of the Eucharist itself. Equally unfortunate, some allowed a celebrant, a single deacon or server or chanter to dispense with constant wearing of a mask while serving, a practice wholly inconsistent with what scientists and medical experts were telling everyone about how the virus is spread in aerosol form that cannot be confined to a particular space. Now, fortunately, at least in some cases, and in some places, other bishops did not insist upon these dubious practices. The Church's theologians and hierarchs remain divided as well on whether remote broadcasting of a liturgy celebrated only by a priest was the best way to continue worship, or whether, as others insisted, watching the liturgy might actually be an act of impiety. It would have been far preferable to have encouraged the faithful to pray the services of the hours or the Typica in their own homes until the worst of the virus, the danger had passed. With the successful production and distribution of the vaccines against the virus, the same kind of divisions that have manifested themselves in the COVID and communion debate surfaced again. Now, there is a long history of suspicion and fear of both inoculation and vaccination that lie behind this phenomenon. But many observers believe, and I think they are correct, that the outbreak of the autism scares of the 1980s, where vaccinations were being falsely claimed to be responsible for triggering autism in children, reflected the deepening suspicion of government, science, and institutional authority in general. The epistemic plague I referred to at the outset may indeed have its more proximate roots in this panic of some 40 years ago. In the case of the COVID pandemic, however, Orthodox hierarchs in various patriarchates did respond more positively and more quickly in favor of receiving the vaccines as they became available. The decision of the ecumenical patriarch to have himself photographed taking the vaccine should have provided a model for hierarchs everywhere, but that did not prove to be the case. When the Patriarchate of Antioch, for example, affirmed the importance of scientific research and the relieving of human suffering and insisted on the faithful, quote, adhering to all health measures requested by competent authorities, whether before or after vaccination, they also unfortunately suggested that, quote, the decision regarding taking the vaccine is a personal decision. While no one doubts that there is an obligation to decide personally in consultation with competent medical authorities if one can safely take a vaccine, it is lamentable that the Patriarchate did not reaffirm that the primary duty of the Orthodox believer in making that personal decision was to continue to prevent harm to others by becoming a vector for the further spread of the disease. Again, I think the principle of agapic love was not sufficiently emphasized. Eventually, when the Russian Orthodox Church by July of 2021 appeared to reverse its earlier hesitancy about vaccination through its spokesman, Metropolitan Hilarion Alfiev, that Metropolitan even went so far as to state that failure to receive the vaccine is sinful, a position with which one might agree. But once again, it is frustrating to see that this teaching was articulated without the nature of the sin being grounded in a lack of love and compassion for the other. And finally, both with regard to the hierarch's reliance upon medical and legal constitutional advice for developing responses to the pandemic. I find it regrettable that the bishops in the United States in particular do not enjoy a mechanism in place that would enable them to make public the names and professional competencies of the virologists and the medical experts that they are consulting. And the same holds true for answering the claims of those who continue to insist that vaccination and masking and social distances and lockdowns are all invasions and threats to religious liberty. It should have been possible and must be possible in the future for the bishops to have consultation and to make known the names of competent legal and constitutional scholars. And I think here particularly of the agnostic, fierce defender of religious liberty, Douglas Laycock, and others like him, who could provide them with the case histories that go back, in fact, to the beginning of the 20th century, determining that city ordinances, for example, requiring vaccination in public and private schools is a reasonable exercise of the police powers of a state. Or in other cases in the 1940s, where the courts concluded, I'm quoting here from one of them, the family itself is not beyond regulation in the public interest, as against the claim of religious liberty, and neither the rights of religion nor the rights of parenthood are beyond limitation. Laycock has warned us that those who insist on an absolute parity between religious and secular rights, and in the case where that insistence actually then looks like religion is being used as an excuse not to help prevent a disaster, that can, in fact, will produce serious backlash if religion is invoked, as I say, to excuse refusal to act in defense of the common good and the common interests of society. Perhaps the most important takeaway I would make from these observations is one that I think we're all familiar with. We all have concerns about the future of the church, the disappearance of many young Orthodox, the overall decline in the number of Orthodox here in North America. But I think that we need to focus more intensely than ever on the problem of adult catechesis and adult education. Now, that focus, I think, cannot be the product of dubious kinds of internet websites and blogs. It must, in fact, be founded on the best advice competent and faithful teachers can provide, both in matters theological and in the realms of the humanities, the hard, and the social sciences. Because, in short, rational sheep cannot be pastured and defended from wolves by any other means. Thank you.
Thank you so much, Father. That was really, really great. And I should mention that there are comments in the chat giving accolades to all three speakers so far. And now I want to turn to our fourth speaker. But before I do that, I want to just remind people that if you have questions, feel free to enter them in the chat. You can enter them now or later, but we'll try to do it. But do it now if you think of it. Our final speaker for this session is Dr. William Christopher Matthews. He is Professor Emeritus of Clinical Medicine, Director of the University of California, San Diego CFAR Clinical Corps. He's a physician and clinical epidemiologist. He specializes in the management of HIV and related complications at the University of California, San Diego. He's Professor Emeritus of Clinical Medicine. And he's going to give a final talk of this. And I, again, have his slides, so I will share screen.
Okay, can you hear me?
Yes, we can.
Okay.
Christopher, can you turn on your other camera?
Yeah, I don't think it's working. It says the video is running, but it's...
Okay, we're seeing the back of your laptop, if that helps.
Oh. Yeah, no, that's the other. Let me just proceed without changing that because I have an iPad that's not working.
Okay.
So just a couple of comments to begin with. What I'm going to present is a updated version of a talk I gave at OTSA several months ago. And listening to Father Anthony just now relieved considerable anxiety that I was experiencing because I'm going to comment on several issues that he very eloquently addressed forthrightly. Next slide. When I first read the text from the communique from the Ecumenical Patriarchate regarding the mode of distribution of Holy Communion, I was saddened to read the uncharacteristically cataphatic statement that, quote, it is impossible that through this mystery of mysteries, any disease might be communicated to those who partake, unquote. I was saddened because if I understood the statement correctly, grounds for dialogue between scientists and the Holy Synod appeared to have been foreclosed. The next slide. As an Orthodox Christian, I understand my faith to be supra-logical, but as a scientist, I trust that my faith is not illogical, nor in contradiction of validated scientific findings. In that spirit, I propose 3 epistemological axioms as common ground for dialogue between science and theology. The first of these is that truth is one. We should be able to agree on a formulation of the principle of non-contradiction, that it cannot be both true and false, that through the reception of the holy gifts, a biological harm could be communicated to the recipient. The second axiom is that the absence of evidence of a causal association is not evidence of absence of such an association. Because a transmission event of Ebola virus or coronavirus or hepatitis A through contamination of the holy gifts has not been proven, does not mean that such a transmission is impossible. To believe otherwise is an example of the appeal to ignorance fallacy. The third axiom is related to the first 2, that demonstration of a validated exception to an absolute assertion disproves the absolute nature of that assertion. Next slide. 3 such empirical demonstrations of communication of disease defined as biological harm through the reception of the Eucharist are the following, one of which Father just mentioned. Gluten-sensitive enteropathy and consumption of Eucharistic bread containing wheat gluten can produce serious illness of the gastrointestinal tract. Second, serious toxic reactions to the consumption of Eucharistic wine by clergy who are concurrently taking disulfiram or antabuse. And third, incidents where communion resulted in the death of the Abu Bakr monks after the wine was poisoned before the liturgy, as documented in a recent book by Coptic priest Father Michael Sorial. Next slide. I do not know in what sense the Holy Synod understands the term disease and the communication thereof. In medicine, however, it is much easier for a physician to recognize the disease than to define it. In the philosophy of medicine, disease is itself a disputed concept. Leading definitions have been categorized as naturalistic, normative, and hybrid. Among the more recent formulations is that of Jerome Wakefield, who defined disease as a harmful dysfunction meeting 2 criteria: failure or dysfunction of an organ or body part to meet its evolutionarily determined function, and 2, the failure or dysfunction causes a social harm. However, this definition does not take into account several critical features of both infectious and chronic diseases, namely the existence of often prolonged preclinical or subclinical states during which damage is accruing, and second, the existence of asymptomatic but transmissible infection that could harm others. Next slide. It is important to understand that the occurrence rarely, if ever, deterministic. For a deterministically caused disease, if the necessary and sufficient exposures are present, the disease will occur. The classically cited example of such a disease is rabies, for which it is virtually guaranteed that exposure leads to disease. But for most diseases, including SARS-CoV-2 and AIDS, we understand that exposure to the pathogen is a necessary but not sufficient condition for disease to occur. If we knew all the component causes, including their critical periods of action, we could predict with certainty who will get sick and who will not. But lacking that knowledge, our ability to predict is probabilistic, based largely on studies of risk factors and associations observed in populations rather than individuals. Next slide. In the case of the novel coronavirus and COVID-19 disease, there has been rapid evolution of public health guidance informed by accumulating evidence and experience in scientific, medical, and community settings. Public health intervention occurs along a spectrum of coerciveness as a function of several factors, including the burden of the disease trajectory or the epidemic curve, the consequences of infection and disease spread, the availability and cost of scientific evidence-supported treatment, prevention, control, and mitigation measures, and competing risks that include economic, political, and community stakeholder priorities and impacts. Next slide. Models of health behavior based on perceived threat and fear include, among others, the health belief model. This model predicts that adoption of health behaviors such as immunization, masking, social distancing, using multiple spoons for communion, cessation of indoor chanting, is determined by the perceived threat of the disease, the perceived severity, perceived benefits and negative aspects of recommended preventive action, cues to actions, and self-efficacy to accomplish the preventive action. Public health mandates and recommendations can be considered as cues to actions. Actions of church leaders, including statements, mandates, and legal action to block certain public health measures, may be considered as impediments to the self-efficacy of clergy and congregants who desire to adopt specific public health measures that have been recommended or mandated. Next slide. SARS-CoV-2 and COVID-19 parallels with HIV and AIDS. I conclude with a few brief comparisons between SARS-CoV-2 and HIV pandemics. The most important difference between the two is the predominant modes of transmission, droplet and airborne for SARS-CoV-2 versus sexual, perinatal, and parenteral for HIV. In both infections, there is a high prevalence of asymptomatic states during which transmission can and does occur. Both infections initially emerged in the context of an absence of biomedical treatments or preventives, leaving only widespread behavior change as the only means of control. In that context, one might ask whether changing sexual or drug use behavior is easier than changing liturgical practice. Just as we speak of safer sex practices regarding HIV, we should speak of safer liturgical practice in the context of COVID-19. Similar tensions emerged with HIV as now with SARS-CoV-2 between epidemic control measures and civil rights of stigmatized minorities, including gay men, Haitians, persons who inject drugs, and sex workers. Do we consider ourselves as persons of faith to be persecuted victims, or can our perspective be broader and more holistic in achieving a shared vision of the common good? Thank you.
Thank you so much, Chris. That was really great. I want to thank all four of our speakers for doing a really great job. I was going to allow some time for discussion among the speakers, but we have so many questions that have come in, and we really only have about a good 25 minutes left, that I'd rather start doing questions. So I'm going to just start with questions, and I'll throw them out in general, and then maybe turn them to a couple of people. So this first one, Hermina, I know you've worked on this. In the first presentation, there was some information given about the vaccines. It would have been good to have had presented the fact that unborn human tissue was used in the production and or testing of all the vaccines. That means use of vaccines is immoral for Orthodox Christians, being we believe in the sacredness of unborn human life.
Okay, so Gail, you have actually more experience over the decades to answer this question. We use this immortalized cell line in research, and these are from voluntary, well, first and foremost, in our vaccine document, which I will share in the chat line, we discussed that there's a difference between growing the virus in this cell line versus testing it. I mean, we needed to test, especially the mRNA vaccine, the Pfizer and Moderna, in a human cell. We don't want to test that in a mouse cell and then inject it into humans. So it needs to be a human cell. And the best model is this immortalized cell line from the voluntary abortions that were done in the 60s, I believe, right, Gail? And other models, other cell lines, I believe, have been tried, and this really is what works well. And Gail, I'm going to turn it to you because I know you
I'll jump in and say a couple of things.
Yeah.
First of all, the only vaccine that was actually produced in cells that came from the aborted fetus is the Johnson & Johnson vaccine. The other two were never grown on in the aborted cell lines. They were tested against those fetal cell lines. Why? They were testing to make sure that the vaccine would not cause any damage to a fetus. And it's the best we can do if we don't want to inject it and see what happens to the fetus directly. So they test them on fetal cell lines. The church has in the past permitted the use of these fetal cell lines so long as there's no new generation of any new ones. We all saw Ecumenical Patriarch got his vaccine. Many of our bishops received vaccines on videos, and some of those actually did come that were grown in aborted fetuses. The fact is that there are several vaccines that absolutely require this. Many companies have worked to stop using those aborted fetal cell lines, but there are no new abortions that are taking place. There are no new cell lines that are being generated. These are from 1960s and 1980s from therapeutic abortions.
Gail, can I just jump in? So I'm going to share in the document. It's a very good question, and we do address this question in the OTSA document written by myself, Gail, Chris, Dr. Kathy Polis, and Helen, and Tava. So here it goes, and there's more information there. Please check it out. Thank you.
Okay, I'm going to go to the next question. And I don't know if this is, I don't know who this is for. I think maybe Cheryl. Can vaccination help prevent spreading COVID to others, or does it only protect the person who is vaccinated?
It only protects the person that is vaccinated, because we do know that even if you're vaccinated, you can still contract COVID. Now it is a more mild form, but once you contract COVID again, you are infectious. So it does not prevent spreading to others if you are infected. Now, of course, if you're vaccinated and not infected, then there's no risk of you transmitting to others. Is that a clear answer?
I think it's very clear. Thank you.
Could I add something to Cheryl?
Go ahead, please.
There is some evidence that although if you get a breakthrough infection after being vaccinated, the peak levels of virus that are recoverable from the nasopharynx are similar to those of someone who was not vaccinated. However, the duration of viral shedding is considerably shorter in a vaccinated person, and that could have an impact on the exposure of other people to that person who had a breakthrough infection.
Great. Thanks, Chris. I think this next one, it's kind of a comment, but Father Anthony, I think this is more beer line, those of us priests who either cleanse or exchange spoons are in the minority. We haven't been reprimanded nor encouraged. I would love an open discussion regarding this within the priests present.
Well, I think your comment is accurate. I think that practices have sort of been all over the map, and it really depends on what part of the country you're in. It depends a little bit on jurisdiction. It depends a little bit on the severity of what people have been facing. I have a limited experience with this. I can't give you examples, from across the country, but I know that certainly in the OCA, certainly in the Antiochian Archdiocese and the Greek Archdiocese, will have done a variety of things, mostly depending upon pastoral judgment about the local situation. How dangerous, how many people do I have? If I have a congregation that is disproportionately made up of immunocompromised elderly people, then I have to take, I think, more aggressive measures than if I don't have that high risk population. I can only share with you what I personally did. I mean, I actually this suggested, and thank God our bishop endorsed the idea that we ended up separating the parish. We basically took our over 65, our communal people, immunocompromised people, people with infant children, and said that's a restricted group, only 10 or 12 people, and on a Thursday we don't even bother to come on Sundays because it's too risky. And so we actually for a time had 2 different services going on to try to deal with that. But that's not certainly been done universally. And I think, again, it kind of depended on just what we thought we were facing in terms of the part of the country you're in, what the rates of infection were. And also, to be quite honest with you, it depends also on how compliant, how obedient your people are. If the majority of your people are masking, if they're social distancing, if they're being really conscientious, and thank God, in my experience, that's what I had. I had a really wonderful group of people with myself and the other priest I serve with. But that unfortunately is not the case across the country. So all I can say is I'm afraid it depends on what you are facing. And my bottom line here is, as I said in the beginning, I think the principle here is do no harm. You will be held accountable for what you do. And God forbid that through any of us as ministers of the mysteries that our people should sicken and die. I mean, that is going to be hard to defend.
Thank you, Father. The next question is for Cheryl.
Oh, Gail, can I share a link about to what Father Anthony was saying? There has been a survey, remember at the OTSA meeting, about the usage of communion spoon across the U.S. May I share that? That might be interesting for some people to see the various churches and the Greek church versus the Russian and OCA and what they are doing. I will share that with the participants.
Okay, thanks a lot, Hermina. That would be great. Yeah, that survey is very interesting. It was done about a year ago, so it's a little bit dated now. Cheryl, next question's for you. Recently, the federal government assumed responsibility for allocating supplies of Regeneron to the states, but I have not heard or read about how well that process has been working. Have there been any states that have not been able to meet their demand for Regeneron?
I can and I cannot answer that. I can only answer that for Florida, which was my experience. In Florida, we never had a shortage of Regeneron. We were able to offer it to anyone that wanted it. And in fact, the state itself opened some Regeneron facilities. We as a health system did charge not for the medicine, because the medicine was provided to us free, but we did charge for the administration. The government did open some Regeneron administration facilities in Florida where it was completely free. You could sign up online and you could go in. I cannot speak for any other states. I apologize for that.
Thank you. There's another question, I guess, probably in your realm, Cheryl, but maybe also in Hermina's. What are the neurologic symptoms that land one in the hospital with COVID-19?
My experience has, and I'll let Hermina answer this as well, but my experience has been people have come in confused, kind of like dementia kind of symptoms. They are they don't know where they are. Their personality changes. I did have one person who became very paranoid. So it's varied, but maybe Hermina has more specifics on that.
I think in terms of the clinical aspect, probably you and Chris, but I did check. There is in postmortem tissue virus that is found in the brain, but there's another aspect, and that is if it causes inflammation. What I've seen from reports is strokes related, like thrombotic events that lead to stroke, these kinds of things. And the virus that in postmortem tissue was also primarily in the brainstem. Really, this is just speculative on my behalf, but we have our respiratory nuclei there in the brainstem. So it's not a good place to have virus on those neurons.
In addition, there have been a variety of peripheral nervous system manifestations, mainly associated with long COVID, such as what's called POTS syndrome or dysautonomias that are very problematic and long-term and very difficult to treat.
Very good. There's a broad question. I have Orthodox friends divided by the issue of receiving the vaccine, and each side offers compelling arguments. Has there been any effort by Orthodox hierarchs, scholars, scientists, and monastics to come together to discuss this hugely divisive reality? In my estimation, Christians on both sides of the debate are talking past each other, often with condescending tones. Now, Hermina, you've sort of dealt with this a little bit with the behavior issue. Maybe you want to start off?
Yeah, I feel I don't have support from the hierarchs. I have reached out to support our vaccine document, and there was some distribution, but very quiet. There is just one priest who has Orthodox priest here in San Diego who has allowed us to do a vaccine session to educate. But generally, we've tried, and I feel I don't have the support to be able to share the information with the Orthodox people.
I think the question, and maybe Father Anthony could actually talk about a little bit too. I think the problem is that there are kind of pro-vaxxers and anti-vaxxers, and those groups often talk past each other instead of actually talking to each other. Father Anthony, I know you've been involved in some of this discussion. Maybe you could take it on.
Well, what I tried to point out in my comments was that, unfortunately, I don't think that let's just confine ourselves for a moment to the Eastern Orthodox. The Assembly of Bishops, is basically still a work in progress. I mean, these men basically are still getting to know one another. There's not a long history of sort of real high regular meetings, knowing people intimately. That's really very recent. If you talk to the bishops, many of them will say, it's the first time I've ever met these people. I don't know them. They're from a different jurisdiction, et cetera. So it's not as if we have a unified church, which also then has a mechanism in place by saying, if we're faced with a health crisis, here are the virologists, here are the scientists, here are the medical people we immediately turn to. That simply doesn't exist, and that is one of the problems that we face in this church in this country. I think, Gail, if you may recall, maybe 10 years ago now, there was an attempt that was undertaken at Holy Cross to put together something called the Orthodox Scholars Initiative. And it was an attempt to actually identify by area of expertise, who could you turn to if you were interested in someone who would advise you in bioethics, who was a canonist, who was a dogmatician. Well, as far as I know, that never went anywhere as far as, the hierarchs actually using something like that. And I think this is our problem. I would not say, and I don't want to be misunderstood here, I would not say that the bishops are indifferent or even that they're hostile. I don't think that's the case. I think they are, quite frankly, floundering. I think that they simply don't have, at their disposal, the mechanisms in place to call upon experts And this is one of the things that distressed me enormously from the very beginning. When I first contacted Gail and then got to know some of the other panelists, when I asked them, well, surely, the bishops must be talking to you. And the universal response was no. When I said, well, then who are they talking to? Who are they? Where are the people that they're talking to? Who's giving them advice? If not, the very few Orthodox scientists and medical personnel that we have in this country. So I think it's a structural problem that is, unfortunately, another manifestation of this horrible jurisdictional mess that we're in. I mean, we are not a united church in this country, far from it. And so therefore, even to address this vaxxers versus anti-vaxxers issue, you have to have a mechanism in place so that people can, with some degree of confidence and trust, say, well, these are our qualified Orthodox people who have gathered together and the bishops are talking with them. And so now we can confidently say that this is what we should be doing. And as I say, that has happened. I think it was better with the vaccination issue than the other, but even there, we had to struggle. I contacted people in my own jurisdiction saying, could we get our own metropolitan to be more aggressive about pointing people to that OTSA website, which said, here are the vaccination issues you need to be aware of. And no, he wasn't willing to do that. And I think it was mostly out of worry that somehow or other this would be seen as, or perhaps he would be accosted by those people who simply didn't want to believe it. So I think this is a deep structural problem in the way the church has failed to come together historically, and we're paying for it.
I want to read a comment by somebody that it touches upon this issue, and I think it's something we at least ought to mention. It is unfortunate that the entire presentation is so incredibly one-sided. Couldn't there have been dialogue with Orthodox priests, doctors, scientists of different opinions on the many issues discussed? Why not allow the expression of differing opinions instead of speaking so very negatively of those Orthodox who disagree? And I'm going to just point out that despite what it appears, the scientific community and the medical community actually speak as one voice in this situation. You might find a couple of rogue scientists or physicians that might say something different, but these views that are expressed are what you will find in the scientific community and medical community. So then what do? We bring in a priest who doesn't agree with this, and we put him up to argue with everybody else on the panel. I mean, it really is a very difficult situation to be able to handle it. Honestly, the medical and the scientific community speak with one voice. We might differ in treatments, we might differ in what we think are the causes, but we all support vaccines and we all support masks. So it's a very hard situation for us. And so I'm sorry for offending people, but that's just the way it is. Hermina, you want to say something?
No, I just want to extend, because in my research, in the article from George Washington University that I'm going to share now, actually in my research, I found out that virtually all church leaders across the Orthodox world support the science and follow the science. Father Anthony brings something important up as well, that maybe the structure is not working there to support us so that we can be supported as reliable sources of information on this topic. But I do want to extend that, yes, as scientists, the majority of us agree, and also virtually all church leaders and hierarchs across are following the science. So I will share that article because that might help. Thank you.
Thank you, Hermina. Okay, another more specific question. Cheryl, regarding your comment about a person who is wearing a mask being protected against becoming infected, is that only for medical grade N95 masks, or does it include masks purchased at, for example, Walgreens or Walmart?
Well, certainly the N95 is the best mask to use. It's not always practical, and there are studies that say that masks made of cloth that have a double layer are fairly protective. I think the most important part is to make sure the mask is over your nose and over your mouth, and that you wash it frequently, because that mask has all your saliva on it. So if you just keep breathing it in, it doesn't really, it's not really effective. I think some of the masks out there that are very thin, that are just one layer, are not as effective. But I would say any mask over the nose and mouth is more effective than no mask.
And may I add why that is? Cheryl, is that okay? So when we cover our mouth, actually we produce a humid environment around our mouth, and that prevents and diminishes aerosolization of viral particles that we might be breathing out if we are infected. So that is key. That's why it works. And that's why Cheryl said any mask is better than no mask. If you want to be more protected yourself, then yes, and 95. And also indoor ventilation is absolutely critical. 100 years ago, there used to be waterborne disease, and today we demand clean tap water in our house. And, now we have woken up because of this pandemic, and we should demand clean indoor air as well from now on, because there's not just SARS, there are other respiratory diseases. Yeah.
Okay, I'm going to end with a final question. And this is a very specific question about San Francisco. The bishops in this country are not saying to priests here to stop disinformation. There's a priest in San Francisco Metropolia recently talking against masks, vaccines, etc., and who got COVID recently and was hospitalized. He has said nothing in his church bulletin about his COVID, or that there are many in his community in hospital due to COVID recently. His church had to even close several weeks, and their school as well. So who is addressing these folks right here in this Metropolia? I guess I'm looking at the ones from California who might have some idea.
Yeah, I think the hierarchs are in a difficult position because there's anxiousness from people. And in my article, I put the example of what happened in 1771, where the people were so anxious they killed the archbishop for his pastoral care for them. I mean, we are at a different time now, but people are getting anxious and very vocal. So the hierarchs are in a very tough position. I don't know what the solution is. Maybe Father Anthony knows.
I think he'll say the same thing.
What Father Anthony has to say is he thanks God he's not a bishop.
On that note, I think that's a good note to end this on. What I'd like to do is turn it over to Randa, because there are a couple of things in the chat that are relevant. One is the mental health work that OCamper is doing that I think should be mentioned here, and the second thing is the availability of this recording to others. People have asked about it in the chat. Once again, though, before we end, I want to thank our speakers who are really fabulous. Did a lot of work to prepare for this. It is very hard to encapsulate everything they said in that 12-minute bite. I think they did an amazing job. Thank you so much. Randa, take it away.
Sure. Thank you, Gail, for organizing the panel and for moderating and inviting the speakers tonight. Thank you all to the panelists. Appreciate your time and your expertise. As I said earlier, the recording will be on the OCamper website later. And the mention about the mental health task force, I do want to note it. And Father Anthony, I want to make sure you know about it, because unfortunately, yes, it's true. There's not a centralized source for our bishops with regard to medicine, but there is now for mental health. And under the Assembly of Bishops, in conjunction with OCamper, there is a mental health task force. It is chaired by Bishop John Abdullah. Dr. Mamlakis is the vice chair, and there are many professionals, mental health professionals, substance abuse professionals, and clergy as well serving. And so we are now that body that the assembly can go to when they have questions regarding how to care for people in the parishes on mental health. So I say that not just to raise awareness about the task force, but hopefully to share some hope. You know, the bishops are paying attention. They are, and they do want to shepherd all of us in the best way possible. So you can find that information on the Assembly's website.
One other question I'd like to ask. There are still questions in the chat that we didn't answer. Is there a way we can have the chat and then we can post the answers as well at some point?
Sure. Well, Gail, you have more experience running these webinars than I do. You tell me how to do it and we'll make it happen.
It'll be saved with this recording. The chat will be saved as
It will be saved. Okay.
file.
All right. And so then I should be able to email that to all of the panelists and we can figure out a way to distribute perhaps to everyone who's registered.
Yeah, that would be great.
Excellent. All right. Thank you. Can I just take 1 minute and ask my question?
Oh, please go ahead.
And I wonder if it's one that others are curious about as well. There is misinformation. There is contradictory information. Who do you all go to? No, let me rephrase that. Who should the public, those of us who are not medical professionals or scientists, where should we get our information that is reliable, data-driven, and credible? Because clearly it's not social media, mostly.
I would say.
Does anyone?
I
Where
would
do
say
we go? What should we be reading? Do you have a suggestion?
I'm happy to. So Dr. Chris Matthews shared the document with me that was published. I mentioned it in my presentation, right, by the Office of U.S. Surgeon General. It's actually a toolkit and how to address, how to identify, and how to stop the misinformation. Right, which is information that is false, inaccurate, or misleading. And there's a checklist there that it goes through. There's more than one thing to do, but you alluded a little bit. And one is to ask several professionals, doctors, nurses, scientists. You can contact me. And,
right, but if I'm reading the newspaper and I see something that I'm not sure about, is it right? Is it not? Where do I go to fact check?
I think I would say one place is the CDC website.
The CDC, okay.
And
It's written for people.
updated almost daily, and they put it in language that a layperson can understand.
Did you say the CDC?
Right. And I would also say that if you belong to a medical system, Kaiser, any kind of system, most of those medical systems do have very good information available to their patients. And that's also a good source for information.
That's a great suggestion. Thank you. All right. Again, I appreciate all of you. And thank you again. And that concludes tonight's presentation. Thank you.
We got instructions on how to save the chat.
Yeah, so if you're in the chat box where you type,